Good evening, everybody. So, shall we start?
Yes. Yes, Moni. We'll start.
Dr. Manoj, are you there?
Yes, I'm there. Can you hear me, Muri?
All right. Yes, I can hear.
Hello, Andrew, sir.
Yes. Very nice to see you. What's the time there?
Sir, it's 2:30 now.
Very good.
Right. Good evening, everybody. We are going to start the Uromet 2.11. Today's topic is urological emergencies. Today, eminent panel is Dr. Anuruddha Abegunasekara, sir, and Dr. Manoj Vikramaratne. Welcome, Dr. Manoj Vikramaratne and Anuruddha, sir. And we will start from the renal injury. So first presentation will do by Dr. Madhushankar Ekanayaka. Madhushankar, you have 15 minutes. So you can do the presentation now. Over to you, Madhushankar.
Thank you, sir. Good evening, everyone. I will be discussing about the renal trauma briefly in this session. Regarding the renal trauma, it's a urological trauma in abdominal trauma is around 10% of all the body injuries, and kidney is the most commonly injured genitourinary organ, and it accounts for 1 to 5% of all trauma cases, and accounts for 25% of all solid intra-abdominal organ injuries. The majority are spleen and liver injuries, and it secondary to then the kidney will follow. When it comes to male to female ratio, it's around 3 to 1. And regarding the bit of mode of injury, the blunt trauma majority 90 to 95%, with mainly the RTA, deceleration injuries, sports, and other accidental injuries. And penetrating injuries, the gunshot and stab injuries, and also the part of iatrogenic injuries, example, percutaneous renal access, and following open surgeries and endourological injuries. When it comes to the renal injury categorization, the grading system, the world most validated system is the American Association of Surgery of Trauma grading system. There are 5 grades according to the CT findings. The grade 1 is the non-expanding subscapular hematoma or contusion. The grade 2 is a non-expanding perirenal hematoma or cortical laceration less than 1 centimeter. Grade 3 is more than 1 centimeter. The grade 4 is a laceration through the corticomedullary junction into the collecting system. The 4A and 4B, 4A is been made majority can manage conservatively, and 4B manage angiographic embolization plus or minus surgery. The grade 5 is the laceration of shattered kidney or the vascular injury, the total renal pedicle avulsion. This is the most validated grading system up to date, and it predicts the morbidity and need of the intervention. Regarding the assessment, the history, the mode of injuries important indicators of the major renal injuries. It gives idea about the mode of injury, gives about the rapid deceleration injury, whether the fall or RT, and most importantly, the pre-existing renal diseases. Usually, when it considered that the pathologically affected kidney gets more damage during trauma, such as hydronephrosis, calculi, the presence of cyst, tumors, and past renal surgeries, and the presence of a hematuria, the visible macroscopic or microscopic. And during the brief examination, the hemodynamic stability, the suspicious features of renal injury in the abdomen thorax, such as loin tenderness, loin hematoma, loin abrasions, masses, and lower rib fractures in both sides. The basic investigations are the UFR4C, the hematuria, the serial hematocrits. We can predict the blood loss and the creatinine as a baseline value in first hour of the injury. And regarding the imaging criteria, usually in trauma, the initial imaging has been already done for suspecting other injuries. But if there is no imaging has been performed at this stage, the criteria for imaging for renal trauma is the presence of macroscopic hematuria and microscopic hematuria with hypotension at any time duration following the incident, and major associated other abdominal or other injuries, and especially the presence of acceleration deceleration injuries and penetrating trauma with or without hematuria is an indication for imaging. What is the best imaging modality? As we all know that ultrasound is as a mode of fast scan. It's a quick, non-invasive and low-cost modality, and it usually detects pre-fluid in the abdomen. And with less accuracy, it can predict the renal laceration, solid organ injuries, but no information about the functional capacity. And it can useful for serial evaluation of renal or retroperitoneal hematomas and the parenchymal injury resulting in the urinoma for the follow-up. And it can help predict the requirement for other further radiological imaging. And the intravenous pyelography, it's largely replaced by the CT and not practiced currently. And the gold standard diagnostic and modality of staging and is the CCT abdomen, mainly in the stable patients. It shows accurate details of renal injury, and it can, with the arterial, excretory and delayed phases, which can diagnose the vascular injuries, the collecting system injuries, as well as other intra-abdominal injuries, concomitant intra-abdominal injuries. It also predicts the presence and location functioning of the contralateral kidney status also. So regarding MRI, angiography and radionuclide scans are not very useful because they are time consuming, and it's the availability and the cost wise also, but that can be also useful in some cases. Regarding the treatment, the management options are the conservative management, neurological techniques, interventional and surgical exploration. Regarding conservative management, this is the major main approach of the treatment. So in blunt trauma, the all grade 1, 2 and 3 patient can be managed conservatively, and some selected cases of grade 4 and 5 also considered in conservative management. And the patients who have unilateral complete artery thrombosis following blunt trauma can manage, in some cases can manage conservatively. Regarding the stable patient should be managed conservatively with close monitoring of vital signs until the gross hematuria settles. Here the supportive care and serial blood test, bed rest, observation and the re-imaging when necessary is practiced. And in the penetrating trauma can be managed conservatively in only cases, only after the imaging and after confirmation of the injuries not involving the hilum, ureter, renal or pelvis, and in hemodynamic stable patient. Isolated grade, low grade 1, 3 steps we can manage conservatively in penetrating trauma, and also the low velocity gunshot wounds with stable patient. If the site of penetrating stab wound is posterior to the anterior axillary line, close to 90% of the renal injuries in this type can manage non-operative. And the stab wounds, the grade 3 or more, that should not manage conservatively, they should be explored. Regarding endourological techniques, these are only indicated when there is active extravasation of urine and collection of the urinomas that not settle with the conservative management, usually followed with stent placement and catheterization. Regarding the interventional radiological approach in renal trauma, angiography with selective angioembolization. These are considered in grade 3 or higher injuries with active bleeding, but not indicated for immediate open surgeries. And the presence of large devascularized segment, active extravasation of contrast in CT, and intimal tears with pseudoaneurysm, and the patients who have perirenal hematoma compressing the kidney and impairing renal perfusion and causing hypertension. Surgical exploration. The major indications of surgical explorations are hemodynamic instability. The patients who have non-responding to resuscitation or transient responders, and the expanding or pulsatile perirenal hematomas detected during laparotomy for the renal trauma or concomitant other injuries, and grade 5 vascular injuries, the major vascular pedicle avulsion. And the factors that increase the chance of surgical exploration in trauma, the high injury severity scores, and the grade 4 injury. The goals of the surgical exploration is achieving the vascular control and go for the renal salvage therapy. The principles are mainly the approach would be transperitoneal approach, and the approach to the vascular pedicle would be gained with the incision to the posterior parietal peritoneum or the aorta, just medial to the inferior mesenteric vein, and also the blunt dissection along the psoas fascia. If there is no damage to the renal pedicle, we can achieve the vascular control with the vascular tapes around the pedicle. And if the hematoma is stable without active cortical bleeding, we can manage the hematoma undisturbed. And if there is active cortical bleeding, evacuation of the hematoma and vascular exploration should be done. This can be achieved with the packing and the use of hemostatic agents and the sealant. If the hemorrhage can be controlled and sufficient renal parenchyma is there, we can consider the renal salvage therapy, like in rhinorrhaphy, the suturing, the partial nephrectomy, and the use of omental so fat bolsters, and with the plus or minus nephrostomy, stenting, and the drain to the gutters. And if bleeding does not resolve, may require nephrectomy. Here, the overall requirement of nephrectomy rates are 13% in renal exploration. So it indirectly indicate that the most kidneys can be managed. Most kidney salvage therapy can be considered in trauma. If damage to the renal hilum is noted, in blunt trauma, repair of vascular injury should be only attempted in single functional kidney or bilateral renal injuries. And if the contralateral kidney is not affected, doing a vascular repair for main artery damage or performing nephrectomy has the same outcome. Then the post-operative management, following the conservative management, repeat scan, and if the patient develops fever, unexplained decrease of hematocrit, significant flank pain, we can consider reimaging. And the following the renal reconstruction, physical examination, the analysis of the urine, renal function, and individual radiological investigations and the nuclear scans for the follow-up. Regarding complications, the early and late, these are the early complications: the bleeding, infection, perinephric abscesses, the sepsis, fistulas, hypertension, and urinary extravasations. The late complications are bleeding, hydronephrosis, calculus, the formation, the chronic pyelonephritis, AV fistulas, and formation of pseudoaneurysms, and bit of hypertension following renal trauma. These are the reasons, and as an early complication occurs due to the external compression from perineal hematoma, that is called page kidney, and as a late complication can occur due to compressive scar formation or renin-mediated hypertension due to renal artery thrombosis or renal artery stenosis. And here the treatment would be the medical and the excision of ischemic parenchymal segment if there is any, and vascular reconstruction, and in such some cases the total nephrectomy. Thank you, sir. My references are EUA guidelines.
Thank you very much, Mahendra. Madhushankar, you have done your presentation within the time. So we will move to expert opinion and expert questions. Aniruddha sir and Dr. Manoj.
We will allow Manoj to ask questions and make comments.
Okay. Dr. Manoj, your mic is mute. Yes.
All right. It was an excellent presentation, very comprehensive. Most of the areas were touched. So the thing is, practical aspects wise, I don't know other people have experience. When I was in Sri Lanka, a couple of reasons for renal injuries were renal biopsies ended up with massive hematomas. I think I don't know whether Suranga has joined. In Ratnapura. There was a massive hematoma, continuous hemorrhage. So we have to consider that as well. Does anyone have experience with renal rupture following ESWL? When I was trained in 2012 with Professor Noel Pereira, a young patient had shattered kidney but managed conservatively following ESWL. But when we dug into the history, we found that this patient has had infection, and because of the risk of postponing it, he hasn't mentioned. When Sohan was there, I mean, Sohan is not connected, I think. Yeah, those things are some causes for renal injury. So, Madhushankar,
Yes.
now, so exploration of renal injury, I mean, exploration of kidney is done for a rapidly expansile hematoma, number one. Number two, if it is pulsatile. But according to the principles, zone 1 hematomas has to be explored. If it crosses for an example, if the zone 2 hematoma crosses the midline, are you going to explore? It's a tricky question, isn't it?
In that
Anuruddha
case,
sir,
yes, sir.
yes. Anuruddha sir, what do you think? For an example, a kidney hematoma is there, and if it has crossed the midline, zone 1, are we going to explore?
Dr. Manoj, whether the patient is stable or not.
No, I mean, whether the patient is stable or not, if there is zone 1 hematoma, midline hematoma, retroperitoneal hematoma, it has to be explored. It's a principle. So are we going to do it or not? To be honest, I don't know the answer. I couldn't find the answer. Anuruddha sir, what do you think? With experience, I don't know.
Yeah.
But
I haven't come across Manoj,
oh, yes.
but I suppose the patient, I mean, if you have done a laparotomy, of course, it will be safe to explore, no, Manoj?
Yes. Yeah.
But otherwise, we can wait, as Muni says, if the patient is stable clinically.
Yes.
But once you are inside, I think better to explore a little bit and see.
So what I thought was, if it is zone 1 hematoma, it could be grade 5 injury with vascular pedicle involved. So
Yes,
if it's a definitive indication. For an example, I don't know how, if the patient how accurate our investigations are. Unfortunately, the center I'm working, they do not touch any emergencies, so they transfer. Yeah, what we do is we are just observers. Sometimes they do not come to this hospital straight away. They go to the major trauma center. Okay.
And the other important thing is in our setup, to decide whether we are going to conservatively manage or not, that is depend on how we can observe the patient and what are the facilities available and how fast we can act to the patient emergencies. Sometimes if we are going to conservatively manage, it might cause more harm to the patient if we can't find a theater time. So in those factors also we have to consider in our setup, isn't
Yeah,
it?
Yeah, Muni, I agree with you, but the thing is, in Sri Lanka, to be honest, I have come across several renal trauma. Almost all were managed conservatively, didn't have to explore.
Yeah.
Luckily, I
Yes,
don't
yes.
know. Yes, I don't know about. I in the past it was different when I was a registrar in periphery. So with a general surgeon, he used to explore.
Even in Polonnaruwa, I received a patient from the Kantale. The Kantale general surgeon did the laparotomy and the retroperitoneal hematoma is there. He didn't disturb the hematoma. And it is a grade 4 renal injury, but ultimately we could manage conservatively that patient.
Yes.
So,
yeah, that's true.
So,
but as Muni says, you need a good HDU at least to observe these patients. And particularly if you are going off for the weekend and if there is no one else, then of course these problems arise. As Muni says, whether to explore and go, whether to keep them, or whether to transfer. Some practical problems are there.
Exactly. Yes.
But as Manoj says, most of the cases can be managed conservatively, no doubt about that.
Any questions you want to ask from Madhushanka or the other candidate
No,
who
Muni.
are?
I think that's all. He made a good presentation, I think. Only thing is conservative management. When are you going to send these patients home? Is there some helpful points in
Discharge
your
guide.
guideline? Yeah. When to sort of send them? Just for my knowledge, I would like to know.
Dr. Manoj?
It's a tricky question. I don't know whether there's an answer for that. But what we did was the last patient we Suranga and myself managed in Ratnapura. He had a deceleration injury while he was working with a jackhammer, and his right kidney was just just touching the anterior abdominal wall, but as well as it was pushed down to the pelvis. So, but it was still functioning, massive hematoma, conservative managed, but we kept around 1 week just to make sure nothing is happening.
There is a question from the participant. What about the patient in shock who has splenic laceration and during laparotomy found to have retroperitoneal hematoma? Should we explore the retroperitoneum? There is a splenic laceration also.
Yeah. So I don't know. This is I haven't encountered this thing. Once the spleen is delivered and once the spleen is clamped, if the patient's blood pressure settles, so anesthetist will give you an update in that situation. If the blood pressure is stable, we can just
Observe.
I mean, without closing the abdomen, we can observe. Just check for pulsatile hematoma and check for expanding hematoma. If it settles, I might take a chance and will observe definitely very closely in an ICU setting.
I agree.
Anand sir, what do you think?
I agree. Go back to the basics. No, if it is not pulsatile, expanding,
Yes.
you just do the spleen and come.
Right. Shall we move into next presentation?
Yes.
Right. So next presentation is ureteric injuries. The presenter is Dr. Mahendra Herath. Dr. Mahendra, you have 20 minutes and you can do the presentation now. Over to you, Mahendra.
Good evening, everybody. Today I'm going to discuss about brief discussion of ureteric injuries. So incidence-wise, it's a relatively rare as it is ureters are protected by their small size, mobility, and posterior location as well as adjacent muscular, skeletal, and visceral structures. And iatrogenic injury during open, laparoscopic, and endoscopic are responsible for majority of ureteric injuries. And injuries usually often missed intraoperatively and may result in significant mortality. Then come to epidemiology, it accounts for about 1 to 2% of urinary tract trauma. And abdominal penetrating injuries, ureteric injuries occurs in about 2 to 3% of cases. And in 1/3 of external ureteric injuries are due to blunt trauma, mostly road traffic accident. And incidence of iatrogenic trauma has decreased in last 20 years due to advancing instrumental technology, training method, and subspecialization of the system. Then etiology-wise, it's a blunt and penetrating trauma, iatrogenic injury during surgery, and irradiation. And when it comes to traumatic ureteric injuries, this should be suspected in all cases of penetrating abdominal injuries and also suspect in blunt trauma with significant deceleration, because PUJ disruption can result with deceleration injuries. And distribution of external ureteric injury along the ureter varies between series, but it is most commonly happen in upper ureter. Then iatrogenic ureteric injury. This can be result from either ligation with a suture or rushing by a surgical instrument or partial or complete transection by unintended scalpel incision, thermal injury, or ischemia from the devascularization. And usually it involves the lower ureter. And most common cause is gynecological operation. And it also occurs in colorectal surgeries, vascular surgeries, especially in endourological surgeries. Usually occult ureteric injury occurs more often than reported, and not all injuries are diagnosed intraoperatively. Then iatrogenic injury during ureterorhinoscopy. This is one of the common cause for iatrogenic ureteric injury, and it contributes up to 70% in some series. And predictors of high-grade injury during ureteroscopy includes male gender, long operative time, ureteral access sheath, insertion time, small proximal ureteric diameter in CT. And the risk factors for iatrogenic injury include in open and laparoscopy surgery, advanced malignancy, prior surgery or irradiation, diverticulitis, endometriosis, anatomical abnormalities, or major hemorrhage. And those are the incidents of ureteric injury in various procedures. You can see there are gynecological procedures and colorectal procedures and ureteroscopic procedures. Then this is a grading of ureteric injury according to the American Association for Surgery of Trauma. There are 5 grades. Grade 1 is hematoma, and grade 2, it has less than 50% of transection. Then grade 3, it caused more than 50% of transection. Then there's a grade 4 injury. It is a complete transection with less than 2 centimeter length of devascularization. So grade 5 is avulsion with more than 2 centimeter devascularization. And how we are going to diagnose ureteric injury? Usually this is a challenging task, so high index of suspicion should be there. And diagnosis is delayed in most cases of blunt and iatrogenic injuries. In clinical diagnosis, external ureteric injury usually accompanies severe abdominal and pelvic injuries. And blunt trauma is also associated with pelvic bone fracture, lumbosacral spinal injuries. And hematuria is a very unreliable because it's a poor indicator of ureteric injury, usually present only in 50 to 75% of patients. And iatrogenic injuries may be noted in primary procedure or later when they present with upper urinary tract obstruction, sepsis, abdominal distension, fistula, urinary incontinence, vaginal or drain urinary leakage, hematuria or urinoma. Then radiological diagnosis. The multi-phase CT is the mainstay of diagnosis in traumatic patient. And CT IV is the examination of choice if you suspect ureteric injury. But most of the time, and the extravasation of the contrast is the hallmark of ureteric injury. But most of the time, there won't be much signs. Only hydronephrosis, ascites, urinoma, mild ureteric dilatation will be present. In unclear cases, you can do the antegrade or retrograde urography. It's one of the best methods of diagnosis in unclear cases. Then prevention of iatrogenic injuries. That depend on the visual identification of the ureter and the careful intraoperative dissection in the proximity of the ureter. And prophylactic stenting can assist in visualization and palpation in complex surgeries. But however, it is not associated with the decrease in the likelihood of ureteric injury. And apart from this evident disadvantages, such as potential complication, increased surgical time and cost, stent may alter the location of the ureter and it can diminish its flexibility of the ureter. Then management. It's depend on the etiology, severity, and location of the injury. If you diagnose immediately, such as ligation injury, we can do the deligation and stenting. And partial injuries can be repaired immediately with stent or urinary diversion via nephrostomy. Stenting is helpful as it canalizes the ureter as well as it reduces the risk of stricture formation. And immediate repair of the complete ureteric injury is advisable as it significantly decreases the need for secondary or tertiary procedures. Ureter is mobilized on both ends and spatulated end-to-end anastomosis is performed. And primary repair by ureterostomy or ureteric reimplantation can be safely performed laparoscopically at the time of iatrogenic injury with good medium-term results. In unstable patients, damage control approach is the preferable with the ligation of urate and diversion with nephrostomy. Later, delayed definitive repair should be done. But late diagnosed injuries are usually managed first by nephrostomy or stent. And endourological treatment for delayed diagnosed ureteric injury by internal stenting, either anterograde or retrograde manner. In failure of this stenting, open or laparoscopic repair is necessary. In gunshot injuries, wide debridement is highly recommended. This is the principle of surgical repair of ureteric injury. Debridement of the necrotic tissue, spatulation of the urethral end, watertight tension-free mucosa to mucosa anastomosis using absorbable sutures, internal stenting, external drain, isolation of injury with peritoneum or omentum. Proximal and mid-ureteric injury. Injuries shorter than 2 to 3 centimeter can be managed by primary ureterostomy. And if it is not possible, ureterocalicostomy should be considered. Large extrarenal pelvis and strictured PUJ, a pelvic spiral flap is an option. In extensive ureteric loss, transureterostomy is a valid option. And reported stenosis rate with the transureterostomy is 4%. And reintervention or revision occur in about 10% cases. Distal ureteric injury. This is best managed by ureteric reimplantation because the primary trauma impair the blood supply to the distal ureter. And question of refluxing or non-refluxing ureteric reimplantation remain unresolved in the literature. Risk of clinically significant reflux should be weighed against the risk of ureteric obstruction. A psoas stitch between the bladder and the ipsilateral psoas tendon is usually needed to bridge the gap and to protect the anastomosis from the tension. In psoas stitch, contralateral superior vesical pedicle may divide to improve the bladder mobility. Extensive mid and lower ureteric injury, large gap can be bridged with Bori flap. Long segmental ureteric injury. This can be replaced with the intestine, but should be avoided in patients with impaired renal function or non-intestinal disease. Following intestinal replacement, the follow-up should be with the serum chemistry to diagnose hypochloremic metabolic acidosis. And the long-term complication of intestinal intervene is, one is stricture, other one is fistula. Then other available options are the downward nephroplasty or long Bori flap also option. In case of extensive ureteral loss or after multiple attempts at ureteral repair, the kidney can be relocated to the pelvis, auto-transplantation. Here, renal vessels are anastomosed to the iliac vessel and ureteric reimplantation will be done. The other option is the buccal mucosal ureteroplasty. It's again option for long segmental injury, especially after failed reconstruction as an alternative to auto-transplantation. The permanent urinary diversion and nephrectomy. Following earlier late repair, up to 38 patients develops second ureteral stricture, requiring interventions or palliative management by indwelling ureteric catheter, nephrostomy tube. When there is a parenchymal loss or functional loss, nephrectomy is needed. This is the summary of evidence from the European Association of Guidelines. So iatrogenic ureteral trauma is the most common case of ureteric injury. Gunshot wounds account for the majority of penetrating ureteral injuries, while road traffic accident account for the most blunt injuries. Ureteral trauma usually accompanies severe abdominal and pelvic injuries. Hematuria is an unreliable and poor indicator of ureteral injury. Preoperative prophylactic stents do not prevent ureteral injury. However, they may assist in its detection. Endourological treatment of small ureteral fistula and stricture is safe and effective. Major ureteral injury require ureteral reconstruction following temporary urinary diversion. This is the recommendation from the European Association Guideline. The visual identity of the ureter to prevent ureteral trauma during complex abdominal and pelvic surgery. Beware of concomitant urethral injury in all abdominal penetrating trauma and in deceleration type blunt trauma. Use preoperative prophylactic stent in high-risk cases. Repair iatrogenic urethric injuries recognized during surgery immediately. Treat iatrogenic urethric injuries, delayed diagnosis by nephrostomy, tube, or double J stent urinary diversion. Manage urethral stricture by urethral reconstruction according to the location and length of the affected segment. Thank you.
Thank you, Mahendra. Anuruddha sir and Dr. Manoj, now you can ask questions.
Yeah, a couple of practical questions, Mahendra. Now, as a principle, we when we do ureterostomy for segmental loss or something, for an example, less than 2 centimeter, you mentioned that you need to mobilize the ureter. How far are you going to mobilize? How do you mobilize? Whether you are going to mobilize up to the, I mean, what do you call, defect up to the adventitia, or just the I mean minimal mobilization to prevent tension.
The mobilization should be done to prevent the tension, sir, not
Okay.
far away, sir. And where we should keep the surrounding fat tissue, sir. We do not have to dissect up to the adventitia, sir. It can revascularize the ureter, sir.
Oh, that's right. Okay. I don't know. I haven't come across patient to offer damage control procedure for after ureteric injury. If it is, I think it's a good. It will be very helpful if you are going to do damage control surgery. If you are going to ligate the ureter, just tag with something non-absorbable, like Prolene or nylon at the end. Then it will be easier for you to find the end. Otherwise, it will be very difficult to find the end of the ureter. What will happen is you will start mobilizing from the kidney and trace the ureter down. You can do it, but if you have tagged it, you will be able to find the edges. Maybe practical, maybe a practical point. Another, sir, what do you think?
Another alternative for damage control surgery is just to put a ureteric catheter and take it out, exteriorize.
Exactly, yes.
Yeah, and put a drain also and come, because a little bit of urine leak will come outside and kidney function will be better preserved, I suppose. Very difficult to say. But I think other than tying, that's also an option if you have a ureteric catheter. Long ureteric catheters, not JJ stents, but when we were senior registrars, we used to put ureteric catheters. Sometimes they're available in the theaters. So you can put that and take it out so that urine will still come out.
And you can even direct it to straight away into the catheter bag. Once when the catheter is there, you can just injure or make a small hole in the catheter, and you can put the end of the ureteric catheter into the catheter. And Mahendra, the other thing is, I don't know, appendix is a viable option for a
yes,
loss of ureter on the right side. Sometimes, yeah, sometimes the appendix is very long. You can have a fairly good length.
Better than the ileal segment.
Yes. So if you are going to use ileal segment, for an example, if the lower ureter is intact and long segment of upper ureter is you can't find the lower segment, I mean large segment of upper ureter, are you going to connect pelvis and the lower ureter with the ileal segment, or are you going to straight away connect the pelvis into the bladder?
I will prefer to make anastomose the new connect to the bladder, sir, because there's a risk of damage.
Yes, you are not going to. I mean, I don't know. I'm not sure. You are agreeing with me or not? Usually, what happens is, I mean, if you anastomose the pelvis with the ileal segment, it should not go and you should not go and anastomose to the lower ureter, the other end. So it has to be bridge between the pelvis and the bladder. And if the lower ureteric segment is not there, you can use the ileal segment, and you can use the remaining ureter, and you can use a ileal segment to bridge the gap. But you can't bridge the upper part of the ureter with ileal segment. It has to be from pelvis to the bladder, or upper ureter to the bladder.
That is because of the distal obstruction can cause more urine leak and complications.
What they say is it doesn't work. And when I was a trainee, I did a blunder, to be honest. I just tried to make the ileal segment narrow, because I just wanted to make it prettier. But if the patient had a leak for a long time, so you don't need to make it smaller.
That means no need to taper the ileum.
No, you don't need to. Just use the ileal segment. Anuruddha sir, do you agree with me?
Yes. However, I would always prefer the Boari flap over all these things.
Yes, exactly.
Manoj. Yeah. Just because ileal segment may look easier technically during the surgery, but I think long-term outcome, Boari flap is far better. And if you are familiar with it, you can raise a fairly long one, almost going up to the PUJ.
Yes.
So if the patient hasn't had previous pelvic surgery or radiotherapy, I think always try to do a Boari flap rather than this replacement with ileum.
Yes, I agree.
Excuse me, sir. Sir, we would like to know your experience on this transuretral ureterostomy in practical aspects.
I will not do it because that will risk the other side also. That's what I said. I would always try a Boari flap. We have managed to go right up to the PUJ, luckily, so far. So, transuretral ureterostomy, I haven't done. When I was in Gaul, very early days, I have done once. That's all. Because Boari flap had been very good. And it's very little complications. I think it's worth trying and become an expert on this. Because all the other options are little tricky and difficult and can have some complications.
Mahendra, what are the structures we can use to replace the ureter?
One is appendix, the other one is ileum.
And you said buccal mucosa, no?
Any more?
Saphenous vein?
And the fallopian tubes.
Or synthetic if it is extra anatomical bypass.
Yeah. Okay. Shall we move into next topic?
Yes, Mani, yes.
Right. Yeah. So next topic will be bladder injury. Presenter is Dr. Chaminda Alahakon. Chaminda, over to you.
Good evening all. Today I am going to discuss about something about the bladder trauma. So when considering the site of bladder trauma, so this anatomical position of the bladder is important. We all know that there is a intraperitoneal as well as extraperitoneal component of the bladder. So the injury wise, it could occur in the extraperitoneal, intraperitoneal, or a mix. So usually the most common site would be the extraperitoneal. It is around 60% is there. And as well as intraperitoneal bladder rupture can occur around 30%, and the mix would be there around 10%. And when considering about the etiology, so we can basically divide this bladder trauma into iatrogenic bladder trauma and as well as non-iatrogenic bladder trauma. And also there is some rare entity where there is a spontaneous bladder rupture also can occur. So when considering the non-iatrogenic trauma, again we can divide them into blunt or penetration trauma. When comparing all the abdominal blunt trauma, this blunt trauma to the bladder is less common condition, where which is usually seen about 2% of all abdominal blunt traumas. And also it may be associated with the pelvic fracture or without pelvic fracture. And when considering the iatrogenic trauma, basically for the practical purpose, we can basically divide it into endourological surgery related trauma, or as well as any other pelvic surgery. Either could be a urological or other surgeries. Moving into this non-iatrogenic trauma, especially with the blunt trauma. So those the common injury would be this extraperitoneal bladder rupture with this blunt trauma. And usually it is associated with the pelvic fractures. The association would be varies from 60 to 90% with the bladder rupture and this pelvic fracture. And if there's a pelvic fracture, that also varies according to severity. It might occur from 3 to 25% of bladder rupture can associate with the pelvic fracture, vice versa. And this risk of bladder rupture would be increased with this severity of the pelvic fracture. If there is this pelvic circle displacement is more than 1 centimeter, or a pubic symphysis diastasis is more than 1 centimeter, or pubic rami fractures, there will be a high risk of bladder injury. And apart from this factor, if there is any bone fragments, displaced bone fragment, that also can directly perforate the bladder. So the bladder injury also has this double AST classification, where grade 1 would be this hematoma or a partial thickness laceration, and also grade 5 would be this bladder laceration, which might extend into the bladder, neck, and involvement of the ureteric openings. So those will decide of the future management of this bladder injuries. And intraperitoneal bladder rupture usually occurs when there is a full bladder with a direct bore into the lower abdomen. So what happened, there is a sudden increase in the intravesical pressure. And we all know that least weakest point of the bladder is the dome. So with this pressure, there will be a rupture of the bladder from the dome, which will result in intraperitoneal bladder rupture. So we have to suspect about the bladder injuries with this pelvic fracture, pelvic trauma. So if there is a visible gross hematuria, so that is an definitive indication for to do this further imaging suspected to having the bladder injury. And also if there's a non-visible hematuria combined with high-risk pelvic fractures, as I mentioned earlier, and as well as associated with the posterior urethral injury, in that case also we have to have a high suspicion about the bladder injury. And also we have to consider if there's any blunt urethral trauma or a pelvic trauma with high injury severity score in the trauma scales. In that case also we have to suspect. And apart from that, patient might present with reduced inadequate urine output as well as inability to void. And also on examination, we might be able to see that there's abdominal tenderness and associated this peritonitis features, and as well as in this primary imaging, there would be this features of urinary ascites or free fluid in the abdomen. And also this urine might absorb from the peritoneum, which will result in the uremia and as well as high serum creatinine level. And if it is penetrating injury, so we can see this entry or exit wounds in the lower abdomen, perineum, or buttocks. So if we are having suspicious of bladder trauma, so that in that case we have to confirm our diagnosis with the imaging. So the imaging modality would be this stress cystogram. So the absolute indication for this imaging would be this visible hematuria with the pelvic fracture, and as well as non-visible hematuria with the high-risk pelvic fractures, and as well as posterior urethral injury, as I mentioned earlier. And this stress cystography, there what we do is we insert a catheter and we do this retrograde feeding of diluted contrast. The recommendation would be a minimum amount of 300 to 350 cc, but we are not going to overfill the bladder, that might further injure. And we can do the imaging by conventional X-ray, this cystography or CT film, but up to date there is no, both have this comparable sensitivity and specificity for diagnosing bladder injury in the trauma setting. And as this baseline investigation in the trauma, we do the CT, but passive filling with the catheter clamp in the late phase of CT IVU might not demonstrate the bladder injury, so it is not recommended instead of stress cystogram. So from the cystogram, so we can identify the bladder injury and as well as the location, whether it's extraperitoneal or interperitoneal. So in the intraperitoneal, so we can see this contrast externalization into the peritoneum, and it's outlined the bowel lobes and abdominal viscera. And in the extraperitoneal bladder injury, we can see this flame-shaped areas of externalization of this contrast in the perivesical soft tissues. Moving into the management of this bladder trauma, non-nitrogenic bladder trauma. So the management options include this conservative management and the surgical management. So almost all extraperitoneal injuries without having any complication, we can manage with the conservative measures. And apart from that, this when considering intraperitoneal injury, that is usually only indicated in this uncomplicated minor perforation during this TURBT or is iatrogenic type of injury, and also if it is less contaminated and very minor and isolated extraperitoneal bladder ruptures in the penetration type of injuries also can manage with the conservative management. So the conservative management includes the clinical observation, continuous bladder drainage with the catheter, and as well as antibiotic prophylaxis. The choice of antibiotic will depend on the local policies. So surgical management usually consists with this bladder closure with preferably with the absorbable sutures, and up to date there is no evidence that suggesting 2-layer is superior to this single layer closure. So the either this repair can be done with laparoscopic or open according to the available expertise. So indication, when comes the indication for surgical management, usually this when comes the blunt extraperitoneal trauma, usually it is managed by this conservative management, but we have to consider surgical management if there's a bladder neck involvement or bone fragments within the bladder, so that might fail your conservative management, and whether there's any concomitant rectal or vaginal injuries or entrapment for the bladder wall. And also, even though there's an uncomplicated extraperitoneal trauma, if patient is going for this open reduction and internal fixation of the pelvic fracture, in that case, we have to go for a surgical repair to reduce the infection of these fixatives, and as well as if the patient is going for this open repair for other injuries, that also indication for surgical management of non-iatrogenic extraperitoneal bladder rupture to reduce the risk of complication as well as to reduce the recovery time from the surgery. So usually almost all cases of this intraperitoneal rupture managed with surgical management to avoid this peritonitis and intra-abdominal sepsis and death. And when consider penetration injuries, yes, definitely the patient with penetration injuries should be managed with the surgical exploration and debridement and this removal of the utilized bladder tissues as well as primary repair. So as mentioned earlier, only these small uncomplicated and less contaminated injuries, less contaminated extraperitoneal injuries, we can manage conservatively. Otherwise, all should manage with the exploration and the primary repair. But during our exploration, we should do this midline exploratory cystostomy to identify this bilateral ureteric openings to exclude any associated ureteral injuries. And when considering this traumatic bladder hematoma, so that is grade 1 double cystic classification injury, so it could be either intra or extravesical bladder hematoma. So usually this intravesical bleeding occurs from the mucosa or the detrusor hemorrhage, and extravesical from the rupture of the laceration of the bladder wall or bladder vasculature. So management again will depend on the clinical presentation of the patient. If there's any bladder clot, we have to go for a bladder wash, and if there's ongoing bleeding, we can do the diathermy, and if there's ongoing bleeding, we can consider arterial radiological embolization. And if it is a extraperitoneal thing, extravesical hemorrhage, and it is uncontrollable, in that case, we can consider laparotomy and packing and even the suturing. Moving on to this iatrogenic type of bladder injuries. So again, it could be external iatrogenic bladder injury or internal iatrogenic bladder injury. So external iatrogenic bladder injury most commonly occur during this obstetric and gynecological procedures, and as well as some urological procedures, especially with this sling procedures, and also during this port placement of the laparoscopy. So main risk factors including this previous surgery, inflammation, and malignant surgeries. And when considering this urological procedures, the most common procedure would be this urethral sling, where this retropubic root, there will be an increased risk of bladder perforation. So this is some summary of this iatrogenic bladder trauma. Here we can see that most of the gynecological procedure, those include again the malignant condition, including the hysterectomy, has high incidence. And even for the general surgical, there is this site of ductive surgeries for the malignant surgeries has high risk. and as well as the urological procedures, that is including this TURBT and the retropubic mirroring procedures. So identification of this external arterial injuries either could be intraoperative identification or a post-operative identification. So intraoperatively, we can see the extravasation of the urine, and we might able to see the visible laceration, and also we might see the catheter, and we can demonstrate the blood or gas in the urinary bag. And the diagnosis usually more reliably can be done with this direct inspection, and if there's a minor injury, if there's suspicious of minor injury, we can do this retrograde bladder filling without installation of dye. Commonly used one is the methylene blue. So, if this perforation is close to trigone, in that case, yes, absolutely, we have to look for the ureteric orifices. And post-operatively, this might present as hematuria or abdominal pain, and as well as reduced urine output or features of urinary ascites and peritonitis with reduced urine output, and as well as increased serum creatinine. If the patient is on a drain, there will be this continuous drain which is more compatible with the urine. So we can assess this drain fluid creatinine level and serum creatinine level to establish the diagnosis of urine is there. And also the post-operatively, we can identify it may be a delayed presentation of the patient might come with the delayed presentation of this iatrogenic bladder injury, those including this vesicovaginal fistula or vesicocutaneous fistula. So usually cystoscopy not indicated for all the type of this iatrogenic bladder injuries, external iatrogenic bladder injuries, but it is indicated especially in this sling procedure to directly identify this location of the injury site. And also, if there's a lack of bladder distension during the cystoscopy, also suggest of the large perforation. So management again depends on the previous principles. If it is a diagnosis intraoperatively, we can close it with the primary repair. And if it is post-operatively, we can again manage according to whether it is extraperitoneal or intraperitoneal origin. So if it is intraperitoneal, surgical management would be preferred. But extraperitoneal, uncomplicated thing, we can manage with the catheter decompression and, if necessary, with the drains. So when moving into this internal iatrogenic bladder injuries, so mainly during this TURBT, the common risk factors would be the large tumor, old age, and pre-treated bladder, including this previous TURBT or intracycle installation of the BCG, and as well as the location of the tumor, including the bladder dome or diverticuli. And also if the tumor is located in the lateral wall, which will due to the obturated jerk. So in this scenario, also the extraperitoneal perforations are more frequently occurs than the intraperitoneal bladder perforation. So identification, we can during the cystoscopy, we might able to see the dark space, and there will be a fat tissue. And if it's a very large one, we might able to see the bowel also coming into the bladder. And also it may be there may be this poor distension of the bladder with the cystoscopy, and there will be this low return of irrigation fluid, and abdominal distension would be there. So incidentally, there are there's a lot of studies shows that is varies from this about 5% of bladder perforation during the TURBT. So site again, we can see there is about 90% is extraperitoneal and less than 10% of intraperitoneal, and this common site is in the lateral wall. So management wise, if it is extraperitoneal uncomplicated, as mentioned again, so we can manage with the conservative management with bladder drainage. And intraperitoneal rupture, if it is a small uncomplicated, in that case we can think about the conservative management with catheter decompression plus or minus with the placement of intra-abdominal drain. But if it is a large one, in that case we have to consider laparoscopic or open exploration and primary repair. But in that case, especially we have to look for any associated bowel injuries, because this diathermy can injure the bowel. So if we are going for a large exploration for larger bladder injuries, so definitely we have to look for the associated bowel injuries. Little bit about this spontaneous bladder rupture. So this is quite uncommon condition. So this is usually reported in this reconstructed or neurogenic bladders, and as well as some patient with binge alcohol consumption or tumors. So the mechanism, this underlying mechanism would be this over distension of bladder with the failure of neurosensory mechanism will result in rupture from the weakest point. so which has high rate of morbidity and mortality. So the early identification with above features would be essential, and the management again as an intraperitoneal bladder rupture, we have to go for a exploration and open repair. So during this conservative manage this blunt trauma with this catheter drainage. So usually we have to do this repeat cystography after about 10 days to ensure this healing, and we can remove the catheter. And if there's an ongoing leakage following that, we have to perform the cystoscopy to rule out any bony fragments. And after operative repair, usually we don't have to go for this repeat cystography. We can remove the catheter after about 10 to 12 days. But if the complex injuries, the EUA recommendation is to do the cystography. And also for the conservative treated internal iatrogenic bladder trauma catheter drainage, we can remove the catheter after about 5 to 7 days according to EA. So principles of open repair, as we all know, advocate to exposure and utilization of catheter, and we have to do the mobilization of bladder, and we close with the absorbable suture without tension, with continuous or interrupted 2-layer or single layer mucosa to mucosa position. And this Bau's recommendation is to go for a suprapubic catheter unless there is a very small injury or simple injury. And they also recommend performing cystography prior to the catheter removal. With this, I will conclude my presentation. So my references are this EUA and Bau's guideline as well as Campbell's urology. Thank you.
Thank you very much, Aminder. Your excellent presentation. We will move to experts' opinion. Dr. Manoj and Aniruddha, sir.
Yeah, I mean, principles are very straightforward, isn't it? I mean, so Chaminda explained it very well. Couple of practical things. Lot of patients are hanging around with urology departments after reconstruction of bladder with bowel segments, mainly right colon. If someone comes with abdominal trauma and abdominal pain, I mean, examination, you have to look for, I think, evidence of previous surgery and evidence of metrophenol, because I think in National Hospital, Manjula sir also will agree, a lot of patients are there hanging around with, I mean, bladder reconstructed patients. So you have to take it into consideration as well. Otherwise, I mean, I don't have any questions.
I mean, some people recommend that after bladder repair to put some methylene blue and check it. Is it really necessary? What did you find in your literature? Because some people, especially gynecologists, keep on asking whether it is necessary when you go and repair the bladders, whether it is necessary to put methylene blue and see whether it leaks.
Yes, sir. Those guideline doesn't mention about those kind of leakage tests, but I couldn't find any evidence.
Yeah, I think it may not be necessary.
With the pelvic trauma, multiple bladder injuries, we might go for the check because we might miss the injuries.
True.
Otherwise, the straightforward cut injury, I don't think we want to check.
True.
What they say is watertight repair, isn't it? So if you are sure you don't need to, following multiple injured patient, yes, Munipriya is right. We need to find out whether there are missed injuries.
Yeah.
Surang is here. Just a quick question. When I go to do a on-table IV, I think the first presentation. Hello.
This is about renal injury, Suranga.
Yes, sir. Because before you move into the genital trauma, just I asked not from you as the on-table IV for presentation. Yeah.
I think.
If it is an unstable patient, if in the renal trauma, if you go into for exploration, then you need to have an on-table IVU to assess the other kidney.
Yeah. So patients who didn't have a chance to have a CT, isn't it?
CT, yeah. And there is another thing, if there is a bilateral renal injuries, so is it the same grade or is it going to upgrade?
It's going to be upgraded by
upgrade
one band
one,
up to level 3.
Yeah, upgrade one. Yeah,
Upgrade
at
one
one.
by- Yeah.
We will move to next topic, that is genital injury. Presenter is Niranga, Dr. Niranga Samarasinghe. Niranga, over to you.
Yes, sir. Can you see my presentation, sir?
Yes.
Yes, yes.
Okay, sir. I will discuss on genital injuries as well as including this urethral injuries as well. So, as the last speaker is going to focus on urethral strictures. Sir. So, when it comes to genital injuries, lower tracts may sustain injury through a wide variety of mechanisms. Although rarely life-threatening injuries, if they are mismanaged, they can cause long-term morbidity and mortality and disability. So the best outcome can be achieved by employing appropriate imaging and identifying the injury and timely management. Sir. When it comes to urethral injuries, the American Association for this surgery of trauma, there's organ injury scale. Sir. There's a blood at urethral meatus. When we are doing this retrograde urethrography is normal, there can be a mild contusion only. In the level 2, there will be elongation of urethra without any extravasation. So it can be stretch injuries. The extravasation of urethrography with the contrast at injury site with visualization in the bladder, that means a partial disruption. If the extravasation of urethrography contrast in injury site without visualization of the bladder, means there's a complete separation. There can be a defect of less than 2 centimeter, or in the level 5, there will be a more than 2 centimeter complete disruption. To categorize this one, there's another classification known as this Goldman classification. There they consider this posterior urethra is stretched, but they are intact, and urethral rupture above the intact urogenital diaphragm, or injury extend through the urogenital diaphragm involving the proximal bulb urethra, or extraperitoneal bladder rupture association, or anterior urethral injuries. So when we first focus on this posterior urethral injury, the spraddle fractures, which involve in the all four pubic rami and fractures, resulting in this vertical and rotation pelvic instability, are associated with this highest risk of urogenital injury, because this posterior urethra is densely adhered to this symphysis pubis via urogenital diaphragm as well as these puboprostrate ligaments. So the bulbar membranous junction is more vulnerable to injury during this pelvic fracture than the prostomembranous junction. So urethral disruption will be heralded by this triad. Patient will present with inability to urinate, blood at meatus, and a palpable gallbladder. The typical signs like this, the high riding prostate or butterfly perineal hematoma may will not always present in clinical presentation. When blood at urethral meatus is discovered, an immediate retrograde ureterogram should be performed to rule out urethral injury, and the patient should be stable for this kind of intervention. In the initial management, we can do the urinary derivation with the suprapubic cystostomy with planned delayed reconstruction. There's a concept of this primary realignment as well. Brief attempt at primary alignment of urethral injury is recognized as an alternative in patients who are stable on presentation, and it can be done either acutely or within several days of the injury. We can combine this with the retrograde or antegrade flexible cystoscope, have been advocated for realignment. After realignment, when the urethral catheter is removed after 4 to 6 weeks, it's imperative to retain a suprapubic catheter, because these patients, overwhelming majority, they, despite realignment, will develop the posterior urethral stenosis. Whether realignment is done or not, the urethral stenosis of 1 to 2 centimeter length typically ensures an overwhelming majority of these patients require elective delayed posterior urethroplasty because of this strict formation in the fibrous tissue. When it comes to delayed reconstruction wise, we can do the procedure in 2 to 3 months because the scar tissue at urethral disruption stable enough to allow posterior urethroplasty. Cystogram and retrograde ureterogram both should be obtained simultaneously, which is known as up and downogram. The endoscopic treatment we are using currently as a direct vision internal ureterotomy. These should be best reserved for selective short incomplete stenosis only, because these partial destruction injuries for which early catheterization has maintained the urethral continuity. The technique like this cut-to-light technique or similar go-through procedures, they will require multiple urethrotomies or long-term dilatation by the patient, which are cumbersome for the patient. So this open posterior urethroplasty is the gold standard one with the perineal anastomotic approach. It's the treatment of choice. Most urethral distraction injuries, because it indefinitely cures the patient without need for multiple procedures. The perineal approach alone will be the most one. The adjunctive maneuvers we can associate with this corporal splitting, inferior pubectomy, and corporal rerouting are often used during the procedure, which were demonstrated during our workshop as well. In the complications, they can have this erectile dysfunction. Some degree of impotence is noted, In some cases, it is up to 82% of patients and a mean value of 50% because this etiology is multifactorial. It can be attributed to this cavernous nerve injury, arterial insufficiency, venous leak, and direct oral injury. When it comes to this anterior rectal injuries, in contrast is this posterior rectal distraction, these anterior rectal injuries are mostly isolated injuries. Most occur after straddle injury or involving the bulbourethra, which is susceptible to compressive injuries because it's fixed location beneath the symphysis pubis. So this small percentage of injuries to anterior urethra result direct penetration injury to penis as well. The contusion and incomplete injuries can be treated by the urethral catheter diversion alone. The initial suprapubic cystectomy is the standard of care for major injuries. We can consider them for delayed reconstruction. The anastomotic urethroplasty is here the procedure of choice in the total obliterated bulbourethra with the straddle injury. So if there's imaging cystoscopy closer to date of repair, we should always re-image the patient to detect the level of injury in this patient. And AUA trauma guideline recommend that follow-up should be done for this patient even up to 1 year after repair. When it comes to female, the female urethral injury requiring intervention is relatively rare because this happens almost exclusively in the process of pelvic fracture, most often having a pelvic laceration in the vagina and the complete disruption of the bladder neck as well. So we can convert into these penile injuries. When it comes to penile injuries, the mechanism-wise, there can be motor vehicle accident, penile fracture, animal bite and burns, and there are complications related to circumcision as well. In the American Association injury scale, there can be simple cutaneous laceration or contusion, or there can be Buck's fascia laceration without any tissue loss, or there can be cutaneous avulsion, laceration through the glands, or meatus, or cavernous, or associated urethral defect of 2 centimeters. When it comes to penile fracture, which we should not as immediate management or emergency management, so there is a disruption of the tunica albuginea with rupture of the corpus cavernosum. Although the site of rupture can occur anywhere along the penile shaft, the fractures are most often distal to the suspensory ligament. Because these are associated with coitus, they are usually in the ventral or lateral aspect, which is the thinnest part of the tunica albuginea. Other causes can be these habitual benders of the penis, and there can be rare cases of excessive masturbation as well. The patients usually describe a cracking or popping sound as during the hysterectomy when the tunica tears, followed by pain and sudden loss of erection, rapid detumescence, and discoloration and swelling of the penile shaft. So depending on the level of injury, if the Buck's fascia remain intact, the penile hematoma remain contained between the skin and tunica. So it will give rise to this typical eggplant deformity. But if the Buck's fascia is disrupted, the hematoma will not be confined, so it will extend into scrotum, perineum, or suprapubic region. Or depending on the availability, the ultrasound scan is the preferred imaging study to evaluate, but it can be taken as a clinical diagnosis as well. In the AU guideline, they recommend MRI is more superior to ultrasound scan, but in the practical setting in Sri Lanka, it will not act as a major investigation. We should consider other differential diagnosis as well because there can be false fractures reported in patients who are present with penile swelling. During excessive vigorous intercourse, there can be a rupture of dorsal penile artery or vein, which can give rise to a bit of similar presentation. Management-wise, there are multiple publications recommending that the suspected penile fracture should promptly explode and surgically repair. Because most penile fractures occur ventrally or laterally, we can use, if we are detected clinically, the ventral vertical penoscrotal incision for the direct exposure. Alternatively, we can use a small lateral incision on the direct site of the hematoma. The usage of this distal circumcision incision may be appropriate when the location of the fracture is uncertain. When we come to the surgery, the closure of the tunical defect, we should done with interrupted 2 or 3 knot absorbable sutures is recommended. This deep co-coral vascular ligation and excessive debridement should not be done. And this partial they can be associated with the urethral injury as well. So this partial urethral injury should be also with a fine absorbable suture or a catheter. Complete injuries we should be debrided, mobilized, and we can do an end-to-end tension-free anastomosis. In uncircumscribed patient, if you are using this distal circumcision incision, there may be a risk of distal prepuce ischemia. If we manage this patient conservatively, according to the literature, there has been a risk of having a complication like penile curvature more than 10% patient, abscess or debilitation plaques in 25 to 30%. So they will need a long hospitalization and time to recover. When there are other associated injuries like gunshot injuries, and there can be animal bite and human bite. The surgical principle wise, both are same. What we should do is immediate exploration, the scope is irrigation, excision of foreign body, antibody prophylaxis, and surgical closure. When it comes to these animal bites, we can do a proper wound debridement and broad spectrum antibiotic, the concern on tetanus and rabies immunization, and we can do a primary closure as well. But in human bites, because of the social stigma, they will present later. Most of the time, we will have to keep the wound open. So when we come to this penile traumatic amputation, which can be a rare presentation, we can do the reconstruction of the urethra and reanastomosis of the scopus bodies with a microsurgical repair of the dorsal penile vessel and achieve good result. But for the ideal management, we should transfer this patient to a facility where these microsurgical facilities are available. But we can do a macroscopic anastomosis as well, where we can anastomose urethra and corporal bodies with preservation of a good erectile function. During the transfer, we should make sure the hypothermic injury to this amputated segment is not occurred and prevent the direct contact with the eyes of the penis. So for the successful reimplantation, there should be a 16 hours of cold ischemia time or less than 6 hours of warm ischemia time. So the ideal management is the microvascular reconstruction of the dorsal arteries, vein, and nerves to prepare the amputated penis. When it comes to scrotal injury, there can be these ultrasonographic signs of rupture of testis with the discontinuity of the tunica albuginea, hematocele, and loss of Doppler signal in a part of the entire testis. So there can be this penetratal scrotal laceration, which can be managed simply with washout and closure. In case of rupture, the most literature advocate for debridement and repair of the tunica albuginea in the acute setting as emergency case. So the testicular injury classification wise, the American Association using the grade 1 is just a simple contusion of hematoma. Grade 2 is a subclinical laceration of tunica albuginea. Grade 3 is a laceration of tunica albuginea with 50% parenchymal loss of the testis. Or grade 4 is a total testicular destruction or avulsion. So the main one is the testicular rupture. So blunt injury usually following result, assault or sport-related incident can result in this rupture of tunica albuginea. So rupture of the testis must be considered in all cases where the blunt scrotal trauma persists and patient will complain excessive scrotal pain, nausea. Sometimes they can have faintish episode as well. There will be swelling and excessive ecchymosis. And the degree of hematoma may be not correlate with the severity of the testicular injury. So absent does not entirely rule out the testicular rupture, and contusion without fracture can manifest as a significant bleeding. So during this ultrasound evaluation, testicular fracture include this heterogeneous echo pattern of the testicular parenchyma, and there will be a disruption of tunica albuginea. During the clinical examination, a non-palpable testis in trauma patient should raise the possibility because there's a risk of traumatic dislocation of the scrotum after the trauma. So management-wise, we should do early exploration and repair on clinical basis for the testicular salvage. It will reduce the disability and fast return to normal activity. Either we can use this transverse or vertical scrotal incision can be performed for successful exploration. Tunica albuginea, we should close it with a small absorbable suture material after wound debridement there. There can be significant intratesticular hematomas. If they are more than 3 times the size of testis, they should be explored and drained, even in the absence of a rupture. So this will prevent pressure necrosis, atrophy, and delayed exploration rate, which is associated with high rate of occipectomy. This penetrating scrotal injuries, we should do a surgical exploration to inspect the risk of vascular vessel injury and vas injury. So as we mentioned, this testicular salvage rate exceed to 90% if you are going to do this exploration repair within 3 days, so early exploration. Whereas these occipectomy rates are 3-fold to 8-fold higher when we are going for a conservative management and delayed surgery according to the available data. When we are considering the vaginal injury, the American Association for Surgery, they have categorized there can be a contusion or hematoma as level 1 or laceration, which can be superficial in the mucosa, or deep, they can go into fat or muscle layer, and there can be complex laceration, which will involve the cervix or peritoneum, adjacent organs like anus and rectum. Now, this will be the common mechanism will be the straddle injury by far the most common one. Account for this 80% of all injuries. The principle wise, we should do a thorough debridement and reconstruction of the vagina. But in the pediatric patient, we should need to explore the possibility of child abuse as well.
Thank you very much, Niranga. The very detailed and extensive presentation, because a lot of injuries you have to discuss within this 20 minutes. You have done it. Dr. Manoj and Anuruddha sir.
Just a comment. Slides
Yes.
are, I mean, overcrowded. Niranga, I think
Yes.
if you reduce the content of the, I mean, you can tell everything, but describe everything. But when the presentation slides are overcrowded, it's difficult to concentrate and all. So your slides are overcrowded, but the content is, I mean, it had, I mean, lot of information. So if you reduce the content within the slide, it will be better, I think.
Yes.
What do you think, Munipriya? I mean, do you agree?
Yes, I am agreed with that, because whoever the person looking for your slides, they have to absorb something from the slide. So when the slide is overcrowded, very difficult to get information from that. That is the thing. So short and sweet. So you can nicely reduce the content sometimes. Anuruddha sir.
Niranga, when you do, you said you will do optical urethrotomy.
Yes, sir.
How many times will you try You said its recurrence is a problem.
Yes, sir.
Roughly, is there a sort of plan? Continue to do urethrotomies, or when will you try a urethroplasty?
We can try this optourethrotomy for 2 to 3 times, sir. But
Yeah,
if there's a recurrence of structure,
yes.
we can have to go for a
Mm.
urethral reconstruction. Sir.
Yeah, that's a safe way, I think. Because polystride injuries, you may be able to do a urethrotomy because you try to avoid urethral reconstruction because of the side effects you mentioned, because most of them are very young people. So you can try urethrotomy and a little bit of self-dilatation also, but try twice or thrice and still it is recurring. I think better to go for a urethroplasty.
There is a question from the audience, the participant.
Yes.
Should we fix the testis after exploration for testicular rupture?
No,
Mm.
I don't think.
In the literature, sir, there was nothing mentioned about the fixation, sir.
But generally what happens is when you repair for a rupture and repair the tunica as well as the paratale or the vaginalis, you get some adhesion formation which will prevent rotation anyway.
Yes.
So it may not be necessary to anchor it separately because you get some adhesions, and I don't think torsion will be a problem in the future.
Regarding optical urethrotomy, sir, the EUA guideline says twice, no more than that.
Yeah.
And when I had a discussion with Professor Chris Chappell, he said first optical urethrotomy, there's a place for first optical urethrotomy. Second one you can do. Third one don't do.
Yeah. That's
so
right.
Yeah, the 2 maximum. Yes, Muni.
Yeah. Niranga, when you do the testicular exploration for testicular rupture, any special things you have to mention the patient and get the consent? What are the things?
Yes. So during exploration, if we find this testis is not viable, so there's a place for orchidectomy, sir. So we have to make sure the patient is a young patient with a childbearing age and the fertility concern of the patient. And we have to get the consent informing the risk of orchidectomy. And due to the injury itself, there can be a associated bias injury as well, sir, which will prevent the further fertility issues of the patient, sir, complicate. There's the theoretical disruption of this blood testis barrier as well, sir, which will future there's risk of antibody formation affecting the other side testis as well, sir.
The practical point wise, you have to explain the patient the discrepancy of the size of the testis after your reconstruction. Initially, maybe a swelling of the testis, but later on it might smaller size. So that is the one thing. Other thing is when you open the testis, there is a risk of infection. This is a traumatic testis. So there is a risk of infection. So you have to inform that part also. Anything else, Dr. Manoj?
If you are going to discuss about, I mean, definitely you are thinking that the patient is going to undergo orchidectomy. Are you, if you have the facilities, are you going to offer him testicular prosthesis at the same setting, or are you considering testicular prosthesis in a different setting? So if you are going to put a testicular prosthesis, what will be the approach?
So these are trauma patients. We should do it, and we should not offer in the acute setting. There's a risk of infection, sir. So we should do it as a planned procedure, sir.
So if you are going to put a testicular prosthesis, what will be the best approach? Is it transscrotal or inguinal?
That was I'm not sure, sir.
I
Yeah,
think
yeah, what they say is inguinal is better. The risk of infection is higher with scrotal approach.
Shall we move into last topic today? Yeah. So next topic will be urethral strictures. It will discussed by Dr. Mohammed Nabil. Dr. Nabil, over to you.
Hello, sir. Can you hear me?
Yes, we can hear you.
Can you see my presentation?
We can see your keyboard as well.
Keyboard. Now I share the slide.
Go to the presentation mode.
Yeah, presentation mode. Yes, sir.
Right. Now
Can you see now?
Yeah, yes.
Right. Okay. Thank you. I'm Dr. Nabil, Hospital Candy. My topic is today urethral stricture and management. So when we consider about the introduction, first we have to know about the what is real definition of urethral stricture, because there are various of series have given a different range of urethral caliber size for the stricture, but maybe symptomatic or asymptomatic. Those main consideration is less than 10 is taken as a when the patient maybe symptomatic or symptomatic. The fixed anatomical narrowing of the urethra is considered as the real understanding, and stricture involving the urethra surrounded by the spongiosum is considered as an anterior urethra, where the spongious urethra is there. That is the main involvement, mucosa as well as the spongiofibrosis, which involve the urethral stricture. And contraction of this stricture will narrow the lumen size and will give rise to urethral strictures. And posterior urethra is a separate entity. I will discuss in the later part. When we consider about the epidemiology, the male sharp increase with the age, incident with age after 55 years of age. Age is around 45. Anterior urethra is the most commonly affected part, around 92% of the time, and half of the presentation by the bulbar urethra. And the true female urethral stricture is occurring around less than 5% in different series, and those are present with the refractory low urinoretic symptoms. In children, it's most of the time it's related to the traumatic, related to the iatrogenic causes, mainly the external trauma. Around iatrogenic cause around 48% and external trauma around 34 to 72%. Usually related to the after the hypospadias repair and meatal stenosis and urethral strictures are reported in around 1.3 to 20% of the cases, depending on the severity of hypospadias and the technique used for the urethral strictures. In some 0.2% in a neonatal circumcision have a meatal stenosis related to the urethral stricture. So when we consider the etiology, any process that injures the urothelium underlying with the corpus spongiosum, like idiopathic is the most 1/3 of the people had, and iatrogenic around 1/3 iatrogenic, post-traumatic around 19%, and inflammatory and infection and congenital causes. When we discuss about mainly the about idiopathic, usually those are unrecognized repetitive perineal trauma. Those are the most underlying factors they describe in the BJ knowledge. And other things are related, like a malignancy also is associated with the urethral stricture with penile cancer. When we about the pathology, urethral stricture, it may be starting from the mucosa as a partial flap, or it may be a circumferential like iris stricture or involving the spongiofibrosis partially involved or full thickness involved, and it associated the periurethral tissue or with complicated with the fistula abscesses. Likewise, that can present. In a EUA, can describe about the severity of the urethral stricture with the gradings from 1 to 5, from 0 with the normal urethra is 0. The caliber has size, they have divided into the grade 5 and given as a until total obliterative stricture as a grade 5. So iatrogenic injuries, mainly the purposes mainly occurs in the urethral instrumentation, mainly where the diagnostic and therapeutic procedures, where we usually therapeutic as a catheterization is the commonest, which is procedures which can in the non-handle and non-trained staffs catheterization where can get the urethral injuries, and during the instrumentation mainly the urologist where the cystoscopic instruments and the therapeutic approach like a TURP and bladder tumor resection where they can get this urethral stricture because of the excessive handling and the time revision later can develop the urethral strictures. So these strictures give rise to infection or inflammation or due to the long pressure necrosis due to indwelling catheters, which can give rise to the urethral strictures. So other things are traumatic injury discussed by the Niranga, mainly the blunt and penetrating trauma. Those are main two types with the mechanism, and external injury and deceleration injuries are the main factor which will give rise to this urethral injury. Mainly saddle injury give rise to the bulbourethral injury, and the deceleration venous urethral injury or associated with other genitourinary trauma as well. So these are the injuries can give rise to the urethral stricture when that considered trauma. When about the inflammatory injury, usually infections, this gonorrhea and chlamydia now have come down due to the early diagnosis and early treatment. Previously, this was one of the commonest condition which can give rise to the urethral stricture, but later this was have gone down due to the early treatment and early diagnosis. And so this other things like an sclerosis is a condition which can give rise to the urethral panurethral stricture or from the meatus. So with the genital skin abnormalities. So urethral stricture. Other section occurs, normally occurs, then there will be a stricture at the point with a short stricture in the bulbomembranous junction. So when it comes to the diagnosing and evaluation, mainly these people are presenting with obstructive voiding symptoms and irritative symptoms as a clinical diagnosis. Otherwise, urinary tract infection such as prostatitis and epididymitis because of the poor flow, and urinary retention, the acute presentation as a urinary retention. Some people have a long history, and patient report outcome measures as when the evaluation they will come into with a recurrent disease. Patient will come with a stricture with a long-standing is a poor flow, and history of possible etiologic underlying urethral infections and post-history of trauma, which can give rise to this clinical suspicion. Then examination where the stenosis or lichen this examination finding. So investigation wise, very important here is to identify the location and the length and the depth and the density of the patients comes usually with this presentation. We evaluate the stricture pattern of the urine flow. Then we can go to the cystoscopy, where we'll find some people have severe stricture unable to pass, or sometimes able to negotiate, but with a with tight stricture. So in this situation, sometimes according to their history, we have to evaluate maybe the traumatic history or iatrogenic history. We have to evaluate in a retrograde integrate urethrogram and endoscopy techniques and other urodynamics. Sometimes may need a ultrasonography to evaluate the thickness of the mucosal, spongial involvement. And sometimes like a pelvic associated injuries, upper posterior urethral injuries and strictures, we have to need the MRI for reconstruction images to for the proceed for the structure reconstruction of urethral stricture. So when you think about the urethral uroflowmetry, urethral stricture patterns, usually there's a flat pattern. It does not have a peak flow. There will be a flat and irregular patterns throughout. Then we can consider the possibility of stricture. So when you think about the ureterogram, the routine evaluation, what we can do is retrograde ureterogram to evaluate the urethral caliber, size, as well as the length of the site of the stricture, and the length of the stricture we can assess. But sometimes in the near to the bulbar urethra, the retrograde ureterography is not enough. Sometimes may need patient antegrade ureterography as well, because to identify this patency of this and the posterior urethral segment as well. If a micturition is difficult, that also will not give a poor clear cut identification with the ureterogram. So there will be here, they have shown in the ureterogram, we have the cutoff in the bulbar urethral region, have a good penile contrast. There will be a bulbar urethral stricture in the film A, you can see. In other area, multiple, in the B, we are getting multiple segmental strictures. Here, the third one have a cystoscopic evaluation from, in the intraoperative, we can see the cystoscopic evaluation through the bladder, as well as from the lower down, you can view contrast and see where the continuity and for the assessment of the stricture length. So ideally, the EUA gives about the guideline when the patient comes with obstructive voiding symptoms and suspected stricture with a uroflowmetry and ultrasonography, and you have, if it is yes, directly go for the cystoscopy and assess the antegrade and retrograde ureterogram, and they'll decide on the thickness according to the, if we think about the spongiofibrosis inside. This is usually not, we are not routinely practiced in our setup, but in the clinical setting, usually you can see the degree of spongiofibrosis, exact stricture length, and periurethral pathology if there is suspected, you can see in the ultrasonography. That is given a EUA guideline. They have given the way how to approach this urethral stricture when there is suspected. So treatment-wise, the observation, where usually some people are asymptomatic. When you try to catheterize, you recognize this patient as a initially it's a normal flow. They have no symptoms, but while you try to catheterize, you are encountering difficulties because of the poor caliber. So, but they are asymptomatic. So that's why I said the vary in between. Usually normal, the EUA considered as a more than 18 to 30, but less than 10 is considered as a pathology. But in between range, they are asymptomatic or symptomatic. We will treat according to that. So those kind of people can treat as observation and conservative approach. Sometimes we sometimes go with the transurethral approach. We have dilate and do for the some TURBs, but their caliber is okay with the urethra. So those kind of patient, we for the urethra we can observe and observe the patient. No need any treatment. So other thing is a dilatation and other direct vision internal urethrotomy, cold and hot method, and the stent is not recommending now for the penile urethra. And open reconstruction is the urethroplasty, and suprapubic catheter where is necessary for the palliative intention. So sometimes if they unreconstruct, or we can consider the ileal conduit. So each of topic I will discuss about the what is the reality and of the dilatation. This is the oldest method and simplest treatment, and is a curative in an early part. The goal of this treatment is to stretch the scar without producing a more scar. So if there is a bleeding while dilatation, that means a scar rupture, stricture rupture rather than the stretched. So that will be a more scar formation. So general dilatation is the one which is recommended. And if it is usually the mucosal stricture with minimal spongiofibrosis, this can be dilate. Otherwise, if there is a significant spongiofibrosis, we should not dilate the stricture. So least traumatic method. This is a least traumatic method. So when it about the internal urethrotomy, so open stricture by incising the transurethral, where usually you make it in the usually 11 and 2 or 10 o'clock position rather than the 12 o'clock position, because there will be a risk of rupturing and extravasation of the urine, and corporal injuries is a more risky. So better to do in the internal urethrotomy and 12 o'clock, 2 o'clock and 10 o'clock positions. And stricture at the bulbous urethra is the and less than 1.5 centimeter. Shorter strictures are more with a saddle injuries, more reliable with the internal urethrotomy success rate. They have a 70% moderate long-term success rate. So we can try up to 2 times as EUA guideline for any stricture. You consider it as an internal urethrotomy. Best option for a bulbar urethra rather than any other penile urethra is not recommended. So there's a stricture rate is more, your revision is more, and you have to do another procedure for any other areas. So success of reconstruction is diminished by multiple pre-urethral dilatation or internal urethrotomies. So common complication is a recurrence. So otherwise, at what I have explained, like extravasation of urine and abscess formation and fistula formation risk, those are with this internal urethrotomies. So after internal urethrotomies, it's home self-catheterization is recommended. Self-dilatation techniques can be recommended for a short period of time. There's various people have tried in a different way, but practice-wise, self-catheteric dilatation can be for some period of time will reduce the recurrence rate. Some mitomycin C with antifibroblast with anticollagen have some what no proven benefit with any intralesional injections, but tried with this kind of treatment with the internal urethrotomy. So with that, short segment bulbar urethra. So this is a neck stenosis following ureteric anastomosis. Because of the time lasers are used in that manner, as a comparative studies mentioned in the EUV towards the vesicoureteric anastomosis stenosis stricture division by laser rather than any other region. So comparative studies has to come in a later part later to compare complication wise, laser comparing the cold knife, urinary retention have more in front, we have not compared, and with the hematuria more common in a cold knife when compared to the laser, and other things, the urinary extravasation more common in a cold knife when compared to the laser according to the literature. So when it about the open reconstruction, the anastomotic urethroplasty and substitution urethroplasty and anastomosis is the things which are mentioned and we are doing. And this main principle here is existent stricture is and re-anastomosis when there's anastomotic urethroplasty, where the fibrosis, the full thickness fibrosis, we have to remove it and good spatulate of the two ends and creating a good anastomosis without tension. So here, where the anastomotic urethroplasty picture I have shown, we are in the bulbar urethral stricture. We have cut the stricture, full thickness stricture, and then we urethra and the proximal bulbar part, and there will be a graft techniques when there is a this is for augmentation urethroplasty. When there is the stricture segment is long and unable to mobilize without tension, in this mainly in the penile urethra, most of the time we have to consider the graft, only graft. So here we can take as a full thickness skin graft or bladder epithelial graft or oral mucosal graft or rectal mucosal graft. And buccal mucosal grafts are now routinely we are practicing. And lip, you can key labial graft, and undersurface of the tongue is a lingual graft. So in those areas, we can take and do the augmentation where the stricture length is more than 2 in the bulbar region or in the P1 in the same sort of stricture penile urethra. The complications in the anastomotic urethra is the cordy formation and dissatisfaction and sexual function. Everything will be where you will divide and anastomosing the stricture site. So different technique have a different success rate, but usually they have no much difference in the these techniques when in the literature. The flap only repair, where you can take the flaps from the nearby genital region. It may be a skin of the genital of scrotum or the penile skin, or it may be a foreskin of the penis, which can take and rotate at the inner prepuce site with a vascular pedicle, where the stricture site. So these are more preferable for the penile urethral strictures. And the literature is clear that only graft of associated with the higher success rate than the tubularized graft or tubular skin islands. So tubular skin grafts and the segments cannot be avoided. The length of these segments. So the meta-analysis of the graft only procedures compared with flap procedures showed equivalent results for the graft operation and flap procedures. So the almost all other procedures have failed. If it is no any other option, the patient is really morbid for the reconstruction process. Other things are perineal urethrotomy, where the complex urethral stricture resulting from lichen sclerosis or previous failed reconstruction or failed hypospadias repairs are the most challenging problem. This is the one of the and good clinical judgment to select a perineal urethrostomy. So that's all I have discussed. Thank you, sir.
Thank you, Nabil.
Yes.
We will move to discussion. Dr. Manoj, this is your entity.
Yes, yes.
To be honest, I don't know whether it was my end problem. I didn't hear the presentation very well.
No. Yes, that's I think Nabil's connection is not clear. That is why time to time we can't listen to his lecture.
All right. Okay.
I
Regarding
think in Kandy, wherever I am, I don't think the connection is poor. I'm in the highest area where I'm doing this presentation.
okay. No worries. Regarding evaluation, Nabil, you in that presentation slide, you have mentioned antegrade and retrograde urethrograms. To be honest, if we are to have a good idea about the urethral stricture length and all, we have to ask about combined urethrogram with voiding phase. Sometimes if the bladder neck is not open, if the proximal part is not filled, we won't be able to identify what it is. Then we have to explore and we have to use certain instruments. So just to plan the procedure, what kind of a procedure you are going to offer, we need to ask for voiding phase with combined ureterogram.
What is that, sir? I couldn't hear what properly, sir.
Yeah, it's combined ureterogram with voiding phase.
Yes.
Then
Yes.
they will, combined ureterogram means you have to put contrast into the bladder, at the same time
Yes.
put the contrast into the urethra, penile urethra, and ask the patient to void. Then the gap, you can have an idea about the gap and what
Yes.
kind of a stricture it is. Otherwise, if the bladder neck is not open and if the contrast is not flowing backwards, you don't know what is there beyond the stricture.
Yes, sir. Yes.
Manoj, giving.
Yes, sir.
No, you continue.
No, sir. No, it's okay.
No. Sometimes what happens is the voiding phase, it's difficult to get because of the bladder neck, this thing, spasm-like thing. So some people give tamsulosin the previous day. Is it a useful thing? Have you tried that?
No, sir. Actually, I don't know. Almost all pictures, except one in private sector, Gampaha. The rest of the urethrograms had,
Voiding phase.
Yeah, voiding phase as
Okay.
well. Yeah.
Right.
Yeah.
Right.
It's a very good argument. Your point is very valid, sir.
Yeah.
the bladder
Sometimes,
neck is
yeah.
Yes, miss, sir. Usually when I come across the mainly traumatic setup urethral strictures. So when we do the voiding and this voiding cystourethrogram, usually this prostate part and the prosthetic urethra part and membranous urethra part is not demonstrated. That's usually voiding twice no occurs. Whatever, because usually like it's also showing like a stricture.
Yeah,
right,
that's
okay.
what I'm telling.
That is what Anuruddha mentioned.
Yeah.
I don't know.
So,
I haven't come. I haven't had problems during. Stay in Sri Lanka. So somehow the radiographer or radiologist and radiographer have managed to provide very good, very good.
Yes.
Yeah.
Sometimes they give a report also in a different way. So we know what the voiding cystourethrogram is not very clearly shown in this prosthetic and membranous urethra. Then we are usually intraoperatively we are handling with the even sometimes cystoscopy as well as in the retrograde manner. We are identify the opening, and then we can identify the where we are.
Yeah.
Yeah, Nabil, if someone has bulbourethral stricture,
yes.
It was the thing when we used to practice when there's a bulbourethral stricture, we just did anastomotic urethroplasty. It is very easy. Is it the concept now, or is it different now?
No, if it is even bulbourethral stricture, if there is no full thickness involvement, we can still consider if it is even a short segment. Really, you can excise and do the stricture because more vascular area, then the stricture rate is less when there is even anastomotic stricture. So if it is a long segment, around 2 centimeter, even if the stricture is narrowed, we can consider the augmentation urethroplasty will be a better option for this one.
Yeah, what they say is, now just to consider augmentation urethroplasty, unless the spongiofibrosis is evident from outside.
Right.
Sorry, I couldn't hear, or I couldn't properly have a look on the slides of you.
I think he discussed most of the things, Manoj. I think these are the few points. Yes. So you say augmentation is far better, no? If we can.
Yes, in younger patients, what they say is if they do not know whether if there's no history of trauma and you can't see any evidence of spongiofibrosis,
right?
What they say is just to do augmentation urethroplasty. It is easier because you can just do ventral inlay procedure.
That's right.
Because you
Yes.
can just cover the graft with the spongiosum, because spongiosum is very thick in that area, and there's a very limited chance of forming urethral diverticulum. So rest of the urethra you can't do ventral inlay, but bulb area you can do it.
Okay. Muni, I think we have come to the end unless you have some more questions.
Yes, sir. And so thank you very much, Dr. Manoj from UK. You are joining with us, and also Dr. Surang also there, I think.
That's the thing.
Yeah. Both of you are almost always helping our juniors. Thank you very much. So this is a very good opportunity for young, even us, to learn a lot of things, how the Western, the developed countries is practicing, and what's the thing we have to do, how we improve ours. So thank you very much, Dr. Manoj, and Aniruddha sir. Always you are with us. You are the giant behind this Uromet.
Only few more months, Muni, huh? Only few more months left.
Well, even after your retirement, sir, you are the person who should come behind us. You and the Neville sir is always helping juniors. We know about that, and thank you very much, sir.
Thank you, Muni.
And few things. Even we couldn't arrange the MCQ for the candidate who sit for this time exit exam. So I think all of you are doing the MCQs and ready for exam. So we will do few more Uromet sessions, and after that we have to stop the Uromet 2. And meanwhile, I think 19th and 20th there is a tram is there. So the senior registrars who is not sit for this time exam, we will give the articles to discuss as a journal club. And
that's good.
Yeah.
That will be in September, Muni.
August 19th and 20th.
No, Muni Priya, that is shifted now.
Okay.
Yeah, that might go to September 2nd and 3rd.
All right, sir.
Yeah.
Because MCQ is on 25th.
All right.
So it will be after. I think if you have time, you have to set up a mock exam. not for MCQs. Mock exams will come for the interview part.
Yeah.
So this tram won't take place till the exam.
Okay, sir.
Good.
Right. So thank you very much for all the presenters, and finally I would thanks our sponsors, always supply with us. So thank you very much for Cipla Pharma to giving this the online platform for education purpose, and thank you very much. So we will meet in next Saturday with the next Uromet session.
Yes.
Okay, thank you very much. Good night.
Thank you. Good night.
Okay, thank you, sir. Thank you, Manoj.